Muy bien, pues les damos
All right then. So we welcome you. We welcome all of the attendees, but we would also like to welcome our panel of experts that will be participating: Dr. Juliet Hallett from Canada, Dr. Peter Kim from Canada as well, Dr. Daniel Anaya Sainz from the United States, and Dr. Rafael Medrano Guzman from Mexico. I am Dr. Oscar Chapa, and I will be taking on the role of coordinator for this session. During this session, we're going to make a presentation, and each one of the experts will be sharing their opinions about the different aspects I will be touching on the presentation. And we will start off by saying that neuroendocrine tumors in general represent scarce 0.5% of all of the malignant neoplasias that are diagnosed. But up to 67% of these neuroendocrine tumors are going to originate in the gastrointestinal tract. From there derives the importance of detecting them, and out of them, 22% are going to have distant metastasis at the moment of diagnosis. Survival at 5 years is going to be based on staging of the tumors. It goes from an excellent 93% when it's about a local disease up to poor 90% when it's a metastatic disease on the moment of diagnosis. So, the appropriate management of the PNET, aside from the digestive tract, will represent a challenge for the surgeon in our time. The incidence in the last 3 decades is believed to have grown significantly until it can be fivefold to be a case for every 100,000 inhabitants. It represents up to 5% of the pancreatic tumors in general, but the great heterogeneity makes it difficult to standardize the therapeutical strategies. From a surgical point of view, we have surgical strategies that can range from oncological resections, extensive oncological resections, and just waiting and observing, and also having parenchyma sparing resections. And the great majority of the pancreatic neuroendocrine tumors are going to be sporadic. In other words, they will not be related or associated to any other disease. However, between 5 and 10% of the tumors are going to be intimately related to 4 genetic syndromes. The most frequent one is the multiple endocrine neoplasia type 1. And in this case, resection will be indicated in tumors that are larger than 2 centimeters. The second syndrome and frequency is the von Hippel-Lindau. The resection will be indicated in the tumors greater than 3 centimeters, or those tumors that have a double growth in less than 500 days, or have mutation on the exon 3. Less frequently, we will have it associated to type 1 neurofibromatosis or tuberous sclerosis. The non-functional pancreatic tumors, PNET, contrary to what could be thought about the functional ones, are going to represent from 60 to 85% of all of the pancreatic tumors. Less than 20% are going to be functional ones. And from these, and this is a serious problem, not only from the functional neuroendocrines or not functional ones, but also the pancreatic cystic, 65% are going to be diagnosed. Patients that are studied because of another cause, and as such findings, they detect a tumor in some part of the pancreas. And having said this, it's logical to think that 50% are going to have metastatic disease upon the diagnosis. And this speaks about the most aggressive characteristics of the neuroendocrine tumors in the digestive tract. This concept validates this. They have a better outcome than a pancreatic adenocarcinoma. but worse than other neuroendocrine tumors from other parts of the digestive tract, as can be the cecal appendix. However, they can be located in the head, on the capital, or the tail of the pancreas. They have no predilection different from other tumors for any special anatomy of the pancreas. And having said this, we will give access to our panel of experts in order to discuss some important aspects that can be read in the literature. And stemming from the fact that these tumors can be incidentalomas, then what the question is, what is the importance of the clinical information, and what is the importance of biological serum markers for the diagnosis of these patients, please? Start my participation, dear Oscar. Yes, of course, Rafa. Yes, in fact, I believe that your introduction has been extremely appropriate. And the problem of the diagnosis sometimes that is doesn't note until the manifestation like neoplasias. You perfectly said this. Only 20% are functional tumors, but not only in the pancreas, but out of all of the gastroenteropancreatic, only 20% of them are functional. They are tumors that are thrombophilic, and when they have functionality in that 20%, they can be one of the weapons in order for early diagnosis. In the lab tests that we do in terms of functionality, the patients that have functionality do better because you have early diagnosis compared to the ones that don't. When the patient has hepatic metastasis, independently of them of functionality or not, these can have the two arguments. But the importance of hepatic metastasis is that it increases to 20 to 50% the functionality in regards to what could be the secretion of vasoactive peptides. And as you said, in 50%, they can start or have an onset. If they're not functional, definitely the only circumstance in which there could be a clinical effect would be if they were in the pancreatobiliary contact. In the angular point, they can have a variant that is neuroendocrine, and as the tumor is close to this crossing, then it's going to give an inherent characteristics of this tumor. When the tumor is in the body or the tail, it would all depends on the circumstances, or incidentalomas, as you've mentioned, or that there is an obstruction or continuity of the symptomatology. This except for the fact that functionality that you've mentioned exclusively of the non-functional groups. Now, the fact that you can believe or that you have the incidentaloma and you see a pancreatic tumor, well, first of all, in the image, you can't imagine that it's a net, N-E-T. You have to start with the evaluation. And if it were exclusively and you already had the intention or the belief that it's a neuroendocrine tumor, it had to be worked on the three main bases. What would be the biological evaluation, the markers, the tomography, chromogranin A in 80%, acetic acid, C5, and if it's in pancreas, which is the most functional, depending then specifically on suspicion, then you would have to have a peptide, a marker, a specific peptide. Then it's definitely important to do imaging. It could be a CT, for example, in insulinoma. The diagnosis is clinical, but the CT would be enough. In the fundamental part, in my opinion, that would be the clinical chart. It's difficult in the function of the biological markers, chromogranin and the acetic acid, and then if from there, if they can do a nuclear study, 80 to 90% of the tumors are well differentiated in such a way that the correct study with that radionuclide would have to be GAL68 or an 8 scan. With little differentiation, that would be the other part, and we will go into that later on. Rafael, Daniel, any opinion about these biological markers in regards to the diagnosis? Are they useful? Are they normally used? You have to open your microphone, Daniel. Yes. Thank you very much, Dr. Chapa. I want to take advantage to thank the Mexican Association for the opportunity of being here with you, Dr. Zamora, the organizing committee, and Dr. Chapa for giving me the chance of being here with the panelists. It seems that you have done a very good introduction to the topic. From the diagnosis point of view, the great majority of the cases are with patients that do not have functional symptoms. In other words, tumors, pancreatic, tumors that are non-functional. They are identified through diagnosis, through imaging. A great part of the times it's a CT, an abdominal CT. This is an opportunity to have an idea or to have a clue that these tumors can be neuroendocrinal. They have characteristics that are a little bit different from the other pancreatic tumors. These are tumors that are very vascular, and that makes it so that we can believe in a neuroendocrine tumor. And in this case, depending on the size, generally what we do, depending also on the treatment that is going to be administered, we will follow the diagnosis with an endoscopic ultrasound and biopsy in order to determine the degree and confirm the diagnosis, and then likewise nuclear medicine study. And what we do at this point is Galio 68 PET scan. And the functionality of the markers, I believe, is in those patients that have non-functional tumors, that is not a diagnosis, and the chromogranin A, although associated with the amount of tumor, is not a very specific test, and that makes it so that we cannot use it as a diagnosis. Sometimes we do it as a follow-up, but we find more reasons not to do it because of a lack of specificity that these markers have. The biological markers, I see the highest functionality when they have to do with functional tumors. Thank you very much, Daniel. Any comment that you want to do, or should we move on ahead, Peter? Julie?
If I might, first off, thank you again very much for the invitation, the opportunity to be on this esteemed panel today. I just want to emphasize what Dr. Anaya just said very eloquently regarding chromogranin A. It's a marker that a lot of people do. It's one of the only ones we know about with neuroendocrine tumors. But in reality, it has very low sensitivity and specificity, such that if you look at the most recent North American Neuroendocrine Tumors Society guidelines, they're completely out of guideline now. So it is recommended against using chromogranin A for diagnosis because it actually can introduce more confusion for both patients and physicians and actually be helpful. And really the cornerstone here of the diagnosis and the staging is imaging, cross-sectional as well as functional imaging with PET CTs and a biopsy to get the grade. The grade is really where, in the absence of functional syndromes, we're going to get most of the information needed to determine treatments.
Thank you. Gracias, Julie. Bien, pasando un poquito.
Thank you, Julie. And now moving on to the topic of the diagnosis and the classification of these tumors, which is complex and difficult to understand in clinical activity. These tumors have a classification based on proliferative activity of Ki-67 and the count of mitosis reported at the number of mitosis in three fields. When we see a biopsy or the sample to the pathologist, the immunohistochemistry is mandatory. They're basically going to check for three markers: chromogranin A, synaptophysin, and CD56. The guidelines indicate that two of these three markers have to be present. Based on this, the original World Health Organization classification was modified from 2017, and this happened in 2017, and these changes occur in 2017 compared to 2010. Would anybody like to comment on the changes, considering that there were new changes than in the one that, in the one in 2019? Peter, would you like to comment about the evolution of this classification, why they're based in Ki-67 and mitosis as well?
Yeah, thank you. I think what you're showing is in 2017. I think the most 2019 has also changed between the well-differentiated neuroendocrine tumors as well as poorly differentiated. And within the well-differentiated neuroendocrine tumors, I think there's also G3, which is also confusing. And that, and then poorly differentiated is neuroendocrine carcinoma. So, I mean, the guidelines have changed. I think since it was accepted like four times now, right? But I think it does take into account the differentiation as well as the proliferative index. I think that's probably the more prominent part of the classification.
Thank you. ¿Alguien más quisiera opinar sobre las?
Would anybody else like to share their opinion of that evolution of the classification from 2019 to 2019? I think it's super important to emphasize what Dr. Kim said. I think that it's a little bit confusing when one starts to read about all of these classifications, or when we're not seeing many patients permanently, to be able to classify and truly understand what type of tumor a given patient might have. And I think that the most important thing as a first instance that should be done is to understand what type of tumor the patient has, because the management is radically different and the outcome is totally different. It's very important to understand the differentiation that exists in between the neuroendocrine or neuroendocrine neoplasias. Their characteristics is that they are well differentiated compared to the ones to the neuroendocrine carcinoma, which is a tumor that is poorly differentiated, bad differentiation, and which is always high grade. To make things a little bit more complicated, the neoplasias also have high grade. They tend to be less. But it's very important to understand this differentiation, because the surgical management is important. In one, it's going to be important and not in the other one. In the endocrine carcinoma, systemic management in chemotherapy is very different from other neoplasias. So this is something I always underscore as the most important part when we are diagnosing and managing these patients, because it's the most important outcome factor, considering that we have 4 variables here. And playing with the 4 variables in terms of the management and outcome sometimes is difficult, as you have said. Julia, I don't know if you would like to comment anything in regards to the classification.
I think that's the key points were hit here. And as a surgeon, the way that I think about this is, in simple ways, maybe compared to some of my colleagues in oncology. But G1 and G2s are diseases where I will consider surgery, and surgery might play an important role. The G3 neuroendocrine carcinoma, so next, is something where the default position is not to operate. I never want to say never, but it's close to never that we can help with surgery in those instances. And the G3 neuroendocrine tumor, so the G3 that are well differentiated, it's sort of a gray area, and it is so new, this entity, that we don't really know. So it's somewhere where the evidence is really building itself right now, and we're understanding really what we can and cannot do, and how we can and cannot help patients with surgical therapies in this particular group of patients. So there's a lot of changes happening right now.
Okay. Thank you, Julie. Thank you very much. Doctor Rafael Medrano, ¿querías comentar algo?
Sí. Creo que,
Dr. Rafael Medrano, would you like to comment? I join in with the comments. It's extremely important, but I think that here we have to consider 2 aspects. Previously, the previous classification, and they're all well differentiated. So if they're all well differentiated, then what's the point or the cutoff point to say that this differentiation is more aggressive than the other one? It's not so like that. Previously, it was not considered, the most aggressive was not a carcinoma, it was a neoplasia among the poorly differentiated. Now it's considered carcinoma. Let's remember two important aspects of neuroendocrine. We know the outcomes prognosis that determines the biological behavior. The first important prognostic factor is that it can be resectable. The best way of treating it, and we will see this later, is with surgery. And the second most important factor is called histological grade. And this precisely is what gives us the histological grade. It takes us to the behavior. A non-differentiated will not give you metastatic disease. If the patients that we have in the small intestine, most of them have metastatic disease and they're well differentiated. That does not determine that they can have a metastasis or not, or a poorly differentiated carcinoma will determine metastatic disease, or the fact that it cannot be resected. These are two different aspects, and this is what this indicates, is to determine the biological behavior, to then define the course to be followed. And about the previous comment, I differ with my colleagues that chromogranin I is not important. The patients increase this, not whether they're functional or not. In the histological analysis, the chromogranin marker has to be evaluated. That determines the peptide that is being released, but not necessarily the chromogranin will determine the functionality. I believe that these two aspects have to have a clinical histological correlation and prognostic values. If there is no additional comment to this, we will move on with the presentation. And we know that one of the most studied tumors from the genetic point of view historically have been the breast cancer, but in second is the pancreatic tumors. Genetically, there's been a lot of evolution, basically in order to know the biological behavior of the tumor, but also to understand therapeutical aspects for it. And this is an example in which the expression of these genes is going to generate stability in the chromosomes. In these tumors, generally, it's going to be associated with larger tumors, larger than the normal ones, and with percentages of Ki-67 that are very high, with a metastatic disease that is early, and so they are defined as more aggressive tumors, and it is present in 48% of the non-functional neuroendocrine tumors, and so this grants them an oncological outcome that is poor. Would anybody like to comment about any experience with genetic studies of these tumors? All right. If not, then we will move on in this. And now, Enrique has, with many of the pancreatic tumors, sometimes we have to establish the location for that. And for that, we're going to use different types of imaging. And first of all, the CT, multi-detector CT, we know that they have more than 128 detectors giving us the image that is very accurate, and universally it is considered the choice for these patients to do appropriate arterial staging and late and a portal one in order to characterize these tumors correctly, because it has been said before, they're hypervascular and they're going to share this hepatocarcinoma washout. They're going to be very intense in the arterial stage, and then in the portal venous part, 5% can be accompanied by calcification. Dr. Juan Sarmiento yesterday presented a neuroendocrine tumor with cystic degeneration, and we can see how odd this cystic degeneration can be neuroendocrine tumors. That's 10% of them, and this CT for that diagnosis and location has a sensitivity of 82%. A specificity of up to 96%. And aside from that, it allows us to establish with each the local extension of the tumor and the resectability, if there is or not invasion to vascular peripancreatic structures, and if it has distant metastasis. And that would be a little bit of the presentation about the CT. I don't know if everybody agrees that the CT continues to be an important tool for the morphological diagnosis and the location of these tumors. Peter? Daniel? Yes, yes, I think it's fundamental to understand what is the ideal study in order to understand the characteristics of the tumor, the ratios or the proportions to the structures like the blood vessels in the mesenteric area and the presence of lymph node. And it's useful in order to plan the surgery. It's not, let's say, the ideal mechanism for the study of hepatic metastasis, but it is enough to give us an idea of the extension of the tumor at a local level and the metastatic level as well. All right. Everybody agrees?
Yes.
Peter?
Yes, thank you very much, Dr. Shepard. I agree with Dr. Sines. One thing that I was going to say is that the CT is essential, but when we plan these operations, at least my preference is to have not depend on only a single modality of imaging. I think before we plan the operation, as Dr. Sines said, that the CT, at least I personally found that it's not as good for liver metastases. I usually get an MR in addition to the CT for that. CT is obviously good for vascular anatomy as well as to look at the subtle changes in the small bowel mesentery. But I think CT is essential, but I think combination of CT-MR and functional imaging prior to pursuing treatment, I think it'd be at least be the personal experience that's been good for me.
Thank you, Peter. Efectivamente.
Yes, in fact, these are the characteristics of the CT, but it is well known in literature that the ideal study in order to establish with the metastasis of a neurohepatic tumor. Your slides are not running, Oscar. It's happening on my side. Did that slide move? No. You can see my presentation? No, I cannot. You are sharing, but I do not see your last slide. Great.
I'm going to go back in. Something happened. Sorry, I apologize. Those technical issues sometimes betray us. Well, that's it. Thank you. So the comments on tomography. Tomography is a highly available nowadays technology, but with very good images. But MRI with gadolinium particularly is the more precise for the detection of liver metastasis, and this is commonly known as gadoxate disodium protocol. Do we agree that to assess metastasis we would be using this resonance imaging? And now move to more invasive studies as endoscopic ultrasound. I do personally believe that it has been revolutionizing the diagnosis and the treatment. And here it mentions that contrast is very important because it increases the sensitivity of the study. It has a higher sensitivity to detect smaller tumors, less than 20 millimeters. We can establish metastasis to lymph nodes, regional lymph nodes. We can establish if there is a vascular invasion. We can find the distance from the primary tumor to the main pancreatic duct, particularly when we want to save the parenchyma. And here I put on the table the importance of the biopsy in those tumors. That is to say, I would like to hear everyone's opinion regarding what you think about the characteristics and the tools that the endoscopic ultrasound provides us in the systematic.
I think overall there's different scenarios in which it can be helpful, and the added information depends on the scenario that we're investigating. So the first one is when we have incidental small pancreatic neuroendocrine tumors that are non-functional, which is so common these days with all the imaging that is being done for other reasons. I don't think in those cases necessarily an endoscopic ultrasound will help. Reason being that often the diagnosis can be made on CT scan or MRI with typical imaging characteristics. And if those lesions are less than 2 centimeters and we're going to be going ahead with monitoring, and they can be safely monitored without necessarily having an EUS. In particular, because the grading, so the Ki-67 grade on an EUS biopsy is quite limited because there's not enough cells to have an accurate Ki-67 grade. If we're looking at getting tissue diagnosis or investigations for a larger lesion, so more than 2 centimeters, something we're looking to treat with curative intent or with palliative intent with systemic therapy, and we need tissue diagnosis because there's no other area to target, then that can be absolutely very helpful. Or if we're looking to assess for surgical resection, for example, with enucleation, as you mentioned, the distance from the pancreatic duct can be measured, and in those circumstances, that can be very helpful. And then finally, the last sort of scenario for me is in the setting of multiple endocrine neoplasia, when we're looking for whether there's multifocal lesions in those patients to know exactly the full extent of disease. That can be very helpful. At least it was in the past. I don't know now with gallium dotatate PET CTs whether those will be better identifying multifocal lesions in EUS. I guess only the future will tell us as we build experience with this imaging modality.
Thank you very much, Julie. Peter, you have any opinion?
Yes, I mean we use endoscopic ultrasound very frequently. Whether this is right or not. I've been burnt a couple of times with a typical looking neuroendocrine tumor, ended up being something else like pancreatic adenocarcinoma. So even if I'm going to monitor somebody who has a less than 2 centimeter hypervascular lesion that is non-functional, discovered incidentally, I do ask for the biopsy. I do agree with Julie is that they don't always get enough cells. They have enough cells just to make the diagnosis of the neuroendocrine tumor, but they may not have enough cells to do the stains for the Ki-67 or the mitotic figure, so they may not be able to give you the grade. At least just my I've had some bad experiences in the past. That's why I do biopsy these, even if I want to follow them. And also, we have a very engaged EUS service, and often they come biopsied already. But I've been using the endoscopic ultrasound quite liberally. So.
Thank you, Pete. Rafa, ¿quieres comentar algo al respecto del ultrasonido?
Thank you. Would you like to mention anything regarding the ultrasound, Rafa? Well, first of all, I agree with my colleagues. The first part of the decision-making process, when you have all the armamentarium, well, that's good. But we know that in our country, sometimes we do not have absolute access. So I think the first part here is if the lesion has certain characteristics that you require, this is usually clinical. The rest is resectability. When it's not resectable, this is the main essential point. When you don't have everything to make decisions, if the tumor is resectable, I think you have to mandatorily perform a biopsy to determine what's coming. I completely agree with you that the best way to have access to this, in my perspective, and I would like to subject this to the opinion of the rest in pancreas, is the endoscopic ultrasound, the EUS. It also allows us to analyze the resectability in the orthomesenteric axis. So if we see the clinical characteristics and if the tumor is resectable, then we understand that it is debatable on both sides, because in the end it's not going to change the therapeutic behavior. It's debatable. I agree. Even if we decide on the strategy of watch and surveil. Daniel, any opinion about the EUS and the biopsy, if it's useful or not? I agree with everything that the panelists have been saying. The main function is the diagnosis with the biopsy. This is the biggest use that I see, and I do it regularly. In some cases, there are some tumors that aren't well delineated through CAT or resonance or MRI. In those cases, the EUS would be useful for better delineating the size the structures and the relationship of the tumor, because they are in frequent cases, just every once in a while. Later, we're going to touch on the topic of the biopsy, but it's very important to me for this to be very clear based on the experience of the clears and the experts in the panel. Now we move to nuclear medicine, which is something that has been evolving significantly in those patients. We all know that nuclear medicine or molecular medicine is a functional image that is based on the expression of the somatostatin receptors of the tumors that are expressed up to 70% of those tumors. The problem is the other 30%, which are not going to express this in our patients. We're going to use somatostatin radiometabolic analogs. It's going to help us stage the tumor and to measure the metastasis at long distance. But also, a very important element is going to tell us about the therapeutic possibilities of those patients based on the expression or the lack thereof of the somatostatin receptors, because this is where the whole therapy can be based on, towards the somatostatin receptors, and with radiometabolic peptides, PRRT for the immunohistochemical diagnosis of the receptors. Now, the question is, well, Rafa and I that have been for a while here, what we use the most is the octoscan. The only contraindication was the lack of type 4 receptors for somatostatin, so it would be a poor study for this, but for the rest, a sensitivity of 90% and specificity of 80%, with well-differentiated tumors over 1 centimeter, with very low spatial resolution, so it wouldn't allow us to measure the resectability of tumors. And there is little interest in tumors that are less than 1 centimeter with non-function. The opinion is that it would have to be abandoned as a protocol for patients, or do you think that it's still useful in some cases? Well, I think that nowadays we have significantly better studies. The sensitivity and specificities that you are mentioning, Oscar, could be with bigger lesions, but the accuracy of the octoscan to be able to identify metastatic lesions out of the primary tumors that are smaller is significantly smaller at the liver and bone, for instance. And that's without taking into account the convenience for the patients, which have to come for 2 days to perform this, to be subjected to the study with a higher load of radiation, and we have a better sensitivity and specificity and accuracy in terms of liver metastasis and bone metastasis with lower radiation and with a single day of study with the gallium doratate, which is what we use, or any similar. So as long as there are resources and the access and possibility, I think it should be done. Very seldom we have sometimes some insurance companies that wouldn't support or cover the payment of those studies, and very seldom we have to perform an octoscan, but this is rare and rarer. Anyone would have a different opinion? Well, I will have to represent the third world, Oscar. I have to speak for them. Well, yes, precisely. When we are working on the guidelines, do we have to tropicalize them, to adapt them? No, we have to do it with the best experience in the world, and our colleague mentioned this. I think that the teams and the radionuclides have been escalating. I'm glad that we have the PET scan, the gadolinium, etc. But at some centers, many centers in the country, in our country particularly, they do not have this. We have been working with this gammagram, which is a gammagram with a marker of somatostatin. But if we talk about it being abandoned in circumstances where you didn't have access to other studies, I wouldn't agree, definitely. We can use it as long as the anamnesis, the interview, the clinical analysis is done correctly. the first part of the endocrine tumor is not the image study with radionuclei, is to think about the clinical characteristics, and we do have to receive training for this kind of lesions. Of course, the new technology and new markers, if we talk about, for instance, treatments, we would require a very sophisticated study because we're talking about a therapy with lutetium-177. In many cases, some centers only have this, and you mentioned this. We did this for many years, and we wouldn't do poorly. We had a group of patients in which we could perform the diagnosis, we could support the diagnosis with this. So I'm sorry that I'll have to defend the study, but there is no other option for me. Well, I'm under the impression, Rafa, that when we used this, we used it more to locate the tumor more than to stage the tumor. When we didn't find the neuroendocrine through another medium, we didn't have the endoscopic ultrasound, obviously, we would use it to locate the tumor, not so much to stage it. I don't know if you would agree with this or not. Yes, I think you're correct. I think it's a very good point, very important point. Very well, so now we move to what we are supposedly doing together, which is the Positron emission tomography, PET, associated with somatostatin analogs marked with gadolinium-68. As Daniel mentioned, this is higher specificity and sensitivity, almost 100% for the detection of neuroendocrine tumors, but higher sensitivity to detect lymph node metastasis and long-distance metastasis, which is very important for the patients. And what's available, as far as I know, we have these three options of somatostatin analogs. I don't know if anyone would think differently. And the importance of this is that it could change the decision of surgeons for therapeutic management in up to 30% of patients. I don't know if you would like to mention something regarding this, Peter or Julie.
I'm one of those that's a bit hesitant to say that therapeutic management changes that often based on gallium-68. I think it's very important information that allows us to do a better job with surgical management, but I don't think that it changes the indication for surgery that often. And that we often find additional disease, but it doesn't mean that finding additional disease is going to stop us from doing surgery, because in most instances in those patients, we don't do curative intent surgery. We go for a debulking and tumor control, like tumor burden control. So I think what it does is it allows us to see better what is the full extent of disease and maybe have more complete debulkings. But whether it changes the indication for surgery, I don't think it's as common as we would like to say in a lot of studies. The second thing is, a lot of the studies that say that it changes management in a third of patients are based on cross-sectional imaging prior to the PET-CT that may not have been complete. So like they would have had a single phase CT scan or no CT enterogram, for example, when we talk about small bowel neuroendocrine tumors. And the changes that triggered changes management based on the PET-CT were actually disease that could have been identified without a PET-CT with a more comprehensive workup. So I think it is, all that to say, I think it is a very important test to do. It definitely adds to our understanding of the disease and the biology of the disease, but I'm not sure it changes management as often as we would like for it to be changed. So in Canada, or at least in Ontario where I practice, we've had access to it for only a few years now because of funding issues. And again, it helps complete better comprehensive treatment, but it's really changed the exact therapeutic route we're taking, whether systemic therapy, liver-directed therapy, or going for surgery, for example. It just refines what we're doing in each of those buckets, but it hasn't moved a patient from one route to the other so far.
Okay, thank you, Julie. Peter, do you have any opinion?
Yeah, I mean, I think we've had access to, and I live in Vancouver, which is on the opposite side of Canada. We've had access to gallium scan for the last about 2.5 years. We're actually doing, one of the oncologists, who's a neuroendocrine tumor specialist, is doing a study. So whenever we order gallium, the gallium as well as the PET is done at the regular FDG PET is done at the same time. And in general, we have ordered, depending more on the PET for the neuroendocrine carcinomas, and then gallium for neuroendocrine tumors per se. One thing I do have found that the gallium is so sensitive that it does make up for the deficiencies of other cross-sectional imaging. As Julie said, I'm not sure if it changes management that much, but I think it does give us a better picture. Number two, what I've also found was that it's so sensitive that the small neuroendocrine tumors that are not well seen in the pancreas, especially whenever I've had some cases where we're looking for insulinoma that is not seen anywhere else, and the patient is hyperinsulinemic. We have found insulinomas based on the gallium scan as well. Knowing that the gallium, they do have a physiologic activity in the unsnate that can be confusing as well, but we're doing it as part of a study, gallium as well as the FDG PET. But I found it quite helpful myself, mainly just because that we're able to appreciate more disease. But as Julie said, I don't know if it truly changes the eventual management per se.
Okay. Thank you. Vamos a avanzar un poco.
Yes, we're going to move forward a little bit. If you allow me, I would just like to pose a comment. Well, the PET really helps us significantly. Sometimes in the small intestine lesions, you do not see the primary less than 1 centimeter or 0.5. The PET is not going to capture it. It's going to capture the lymph node activity, which is usually very extensive. Now, I'm going to ask the question to the panel. Those that are well differentiated, we mentioned this, the ideal radionucleus would be gallium-68. When they're not well differentiated, gallium-68 is not going to work. We have to use FDG. So the question is, how do I select the radionucleus?
So there's a spectrum between gallium-68 and FDG of sort of cross positivity. So as tumors get less differentiated, the avidity to gallium-68 goes down, avidity to FDG goes up. So there's this thing called net PET score that was created in Australia and is being validated in many centers across the world now, where they do both FDG and gallium-68 and come up with a score. So the score is close to 0 if it's very gallium-68 avid, for example, and no FDG avidity, and it's super high if it is FDG avid and not gallium avid. And then in between, it provides a spectrum of where the disease stands. My personal feeling is for diseases like, very well differentiated grade 1 neuroendocrine tumors, it doesn't change much because they're not going to be FDG avids. In the very super high Ki-67, 80, 90% poorly differentiated neuroendocrine carcinoma, it doesn't change much either. Where it helps is those in the middle where we're never sure exactly what to do. So for example, the high grade 2s or the well-differentiated grade 3s. And for those diseases, I feel like having both is probably where the sweet spot is and where it's going to be very helpful to know where they stand on that spectrum. And if surgery, for example, if they're at the beginning of the spectrum with more gallium avidity, less FDG avidity, this means that surgery would be helpful, for example, because it's better biology. And if you get to the other extreme where there's more FDG than gallium, then maybe systemic therapy will be more helpful. But this right now is all hypothetical, right? It's under investigations. But it's really, from my perspective, it's the future of tailoring therapy to biology in this disease beyond using only a Ki-67 index.
Correcto. Recordemos que miden cosas diferentes.
Correct. And let's remember that they measure different things. PET with oxyglucose fluoride is going to measure metabolic. And that's why we see the characteristics of the tumors that have to be assessed. And it basically refers to tumors that do not have the expression of the somatostatin receptors, which is that 30% that we already mentioned. And in neuroendocrine carcinoma, there are poorly differentiated tumors that definitely will be seen with the PET with oxyglucose fluoride, and those that are well differentiated but with KIT 67, because we're going to measure the metabolic activity. Would anyone like to mention anything about the studies, or can we move forward? Very well. So we move forward. Now we move to what brought us here to this session, which is the surgical treatment. The surgical treatment of those patients, sometimes I believe that is overestimated, sometimes it's underestimated. And here we will try to clarify what would be the sweet spot or the right position for the patients. We know that the management has been changing in the last 30 years based on the better knowledge of the natural history and the biological behavior as well. So this has motivated that in some cases we can have a conservative behavior, and so the radical surgery would not be mandatory in all cases. Generally speaking, it's nowadays accepted that it should be avoided in indolent small tumors with a cutoff of 2 centimeters, as we're going to see later, and without a question, the decisions have to be made in a multidisciplinary, strict scenario. It shouldn't be a decision that falls to the surgeon alone, but they have to share the decision with specialists in endocrinology, in chemotherapy, etc. So I'm going to show you a very simple schematics that will try to show the critical pathway of the management of the patients. And now we're going to focus only on those algorithms that involve non-functional tumors, where it's been described that non-functional tumors over 2 centimeters, or regardless of the size with symptomatic patients, or regardless of the size, tumors that would cause the dilation of the main main pancreatic duct, should be candidates for surgery. What kind of surgery? Well, non-functionals over 2 centimeters should be going through a standard resection, as we're going to see later, and tumors under 2 centimeters could be candidates to resections to save the parenchyma. And in the red arm, what it says, we have non-functional under or equal to 2 centimeters, but we're going to introduce a variable that so far we haven't assessed, which is that they have to be in grade 1, low grade, asymptomatic. And then we can opt for a policy of just wait and see. So I'm going to leave this on the table. What are the tumors that we have to operate? Do we agree with the simplified algorithm, or are there any comments regarding this?
Daniel.
Sí, gracias, Oscar.
Daniel?
No,
Sorry, Oscar. Thank you. So,
es muy práctico desde el punto de vista de cómo vemos.
First, I think this algorithm is very convenient from the perspective of the analysis of the patients. I think that on a day-to-day basis, when we assess each individual, I think we have to take into account more things besides the size, grade, and symptoms, particularly in patients in a spectrum where they have tumors that are smaller than 2 centimeters. And generally speaking, I think that the selection of grade 1 or asymptomatic, etc., is focused on the aim of the surgery and if this is going to change the survival or the quality of life of the patients. So if we have this and if we take it into account, we are going to start searching for the prognosis factors that are very well or more or less established there, but it's also important to understand that if I perform the surgery, what is the survival and what are the complications and the quality of life of patients also regarding this. So, for instance, a patient that is 75 years old with an endocrine tumor of 1.5 centimeters that would have a Ki67 of 4%, that would have cardiovascular diseases and other things, most likely the tumor, even though it's second grade, is not going to lead the prognosis or the survival of the patient. However, performing surgery in those patients is going to have a higher risk of complications that could affect their quality of life and the quality of life in the end of life. So it is important to understand the algorithms and to use them and let ourselves be guided by them. But it's also to understand in an individualized way what we are trying to achieve. And it's very important, this, because when we talk about the adenocarcinoma in pancreas or colorectal cancer, we are trying to cure the patient. We want to cure the patient or to extend life with the measures. But in neuroendocrine, because they are indolent, are somewhat different. And this is a paradigm that I like very much, and I sometimes like to use it in other diseases, which is the paradigm of manage it more like a chronic disease. And from that standpoint, to manage this as a chronic disease is important in terms of the quality of life of the patient and the alternatives, and what or which one goes better toward the specific purpose for the patient. I completely agree with this, Daniel. Thank you. Peter, any thoughts about the algorithm that we're showing here?
No, I think it's a good algorithm. I agree with it in general. I also agree with the fact that we have to have something just so that we can make decisions. And but I also agree with Danielle, who just said that it is a algorithm and it's a guideline, but we have to put it in the context of each patient.
Perdón la interrupción. Quisiera yo entender entonces.
I'm sorry for this interruption, but I would like to understand then that we all agree that tumors that do not qualify for resection should be biopsied to be watched and surveilled correctly. Is that a reality?
Yo considero, Oscar, que
I believe, Oscar, that indeed, as my colleague mentioned, we have to measure the resectability and the operability. Those are the basic concepts to determine this. If the patient is not operable, then that's it. We have to look into other aspects. If it's a neuroendocrine, then he hit jackpot, because this is an indolent class, most of all. However, the size, even though it's an aspect for certain types of staging, it would not confer, even though it's low or intermediate grade, that it's not going to evolve. And let's remember that in neuroendocrine tumors, the GI tract, the most aggressive ones are pancreas and then small intestine. So we have to consider that if we're talking about an insulinoma, for instance, then you have all the aspects. But if we're talking about a carcinoma, then the indolence should have to be well measured in these terms. You have to biopsy it? Well, yes, of course. There is no question that you require biological evidence to be able to determine more relevant aspects in terms of vigilance per se. If the patient has the possibility to be resected, in my opinion, I think it has to be performed if it's operable and resectable. Now, if the lesion, once again, if it's a neuroampular or if it's in the pancreas and it requires a Whipple, then depending on the experience of the center where this is happening, in the end, this would have a price to be paid in morbidity or mortality even. But if it's in a reasonable range, at the end of the day, I think there are two prognosis factors that are going to lead this disease and the treatment. First of all, the resectability of the primary lesion would be an independent prognosis factor. The resectability of liver metastasis, second independent factor, and the grade. Well, thank you, Rafa.
Thank you, Rafa. Julie, I'm very much interested in your opinion for this patient in the red square, where we have a tumor that is not functional, less than 2 centimeters, asymptomatic, in a patient that's 6 years. Do I do biopsy? Do I just monitor with biomarkers, with functional studies? Or what do you do in your center?
Yeah, so the approach that we've taken is consistent with the Canadian guidelines that were released a number of years ago. So less than 2 centimeters, non-functional, asymptomatic, sporadic. So there's no multiple endocrine neoplasia associated with it. Those patients are observed based on typical imaging. The only reason we would do a biopsy is if the imaging is not typical. When imaging is typical, whether on CT or on MRI, in general, the only differential diagnosis would be either a hypervascular metastasis, from example, a melanoma and RCC, and there is usually a history that comes with that, or it's benign lesion like splenomegaly, for example. So because of that, we do not biopsy to confirm histology. So that's number one, when there is good typical cross-sectional imaging. The second thing is, because as what I mentioned earlier, if you want to confirm the grade with an EUS biopsy, I don't think that's the right test. Because you might confirm the grade and feel very happy, but it doesn't mean it's the right grade because it's not accurate enough because the number of cells is not sufficient. That's also consistent with the North American Neuroendocrine Tumor Society guidelines, where they say that lesions that are can be observed without necessarily an EUS biopsy to confirm grade or histology when imaging is typical. And one thing I would say about this is we're all worried about the G3s and missing some G3s. The reality is grade 3 pancreatic neuroendocrine tumor do not show up as lesions less than 2 cm isolated with no enlarged node and no metastases. So there's a number of series to support that. There's a case series from Memorial Sloan Kettering. There's another series from Toronto General Hospital in Canada that monitored prospectively those patients that are being observed, and none, so absolutely zero patient in those two series progressed to metastases or progressed to unresectability. There is very few that had to be operated, and the main reason to be operated while on monitoring was for patient anxiety, not for tumor reasons. So I think that what tells us is, with typical imaging, less than 2 centimeters, sporadic, non-functional, it is safe to observe without a biopsy, and that's consistent with current guidelines. And the reality is, so I don't know about your practices, I work in a trauma center. So they do about 15 pan-CT scans per day, and the number of pancreatic neuroendocrine tumors measuring 6, 7, 8 millimeters that are caught on this is unbelievable, and we simply wouldn't have the ability to biopsy all those lesions. So it's also a very practical reason.
Okay, thank you very much. Excellent commentary. You agree with that?
Are we talking to me?
Yes. Sorry.
That's good. Thank you.
You agree with Julie?
Yes, I do. Thank you.
Okay. Daniel?
Daniel.
Totalmente de acuerdo.
Totally agreed. I think it's a very complete and grounded comment. All right, then moving on to our ground, and let's now comes the decision. This is a patient that will be benefited with the surgical treatment. And in this case, I want to pose several things. Standard pancreatic resection, who will get them or not, considering the standard pancreatic, the duodenectomy or the distal pancreatectomy. Practically, everybody agrees that a basic lymphadenectomy has to be done, and preservation or sparing of the spleen will depend on the spleen compared to the parenchyma sparing resections. But we know that in terms of pancreatic complications, they can have higher complications than the former ones, and the discussions whether it should be selective node detection. For these tumors, I ask you to take into consideration the possibility of endocrine failure in one or the other procedure, the possibility as well of exocrine insufficiency, but particularly the possibility of greater complications like the fistula. What would be our criteria? For which patients would we choose standard pancreatic resections, and in which the sparing of the parenchyma? Peter?
In general, if it's a functional small neuroendocrine tumor like a melanoma, that I can enucleate in on the superficial location, I've been recommending that. Once the patient meets the criteria for resection, so greater than 2 centimeter, non-functional, I've been offering them standard treatments, such as if it's deep in the head, I've been offering them pancreatic duodenectomy. If it's in the tail, I usually offer them standard distal pancreatectomy. But in terms of enucleations, if I have a multifocal neuroendocrine tumor, and if it's a young patient that I don't want to do a total pancreatectomy, we would do combined major pancreatic resection and then enucleation if possible, and accept the pancreatic leak rate.
We have a high risk of postoperative of fistula pancreatic postoperative. No? What do you think about 45% risk for postoperative pancreatic fistula in enucleation or in central pancreatectomy?
Yeah, I think for enucleations, yeah, the leak rate is high, but usually it doesn't result in mortality, and also usually we would enucleate body and tail in select cases, and those patients actually do well long term. So I don't I don't enucleate often, but when I do, we always leave it drain and accept that the patient will likely leak, and then we just manage the drains after.
Okay. Daniel, criterios para preservar.
Daniel, the criteria to preserve the spleen, or would we systematically have to do the splenectomy? I think that in this case, it's more related with the location and the aggressiveness of the tumor. Obviously, if we want to do a lymphadenectomy because the tumor has lymphatic nodes and sizes, a special size, or with compromise or involvement of the splenic vessels, in that case, we should always do with splenectomy, and in such a way that in the way of doing distal pancreatectomy with sparing of the vessels or preservation is for the patients that have an anatomy of the tumor for smaller, no compromise of the blood vessels, they're distal, and in the few times I do it, basically I do dissections of the vessels. And we speak about this, we do speak about enucleation, and all of a sudden in my practice is a little bit different. I do this in a different way as others, but the reality is that great part of the times I manage these patients pancreatoduodenectomy or distal pancreatectomy with splenectomy. It has to be very obvious if each patient would be the ideal one for enucleation. Many times the complications can be catastrophic and harder to manage. And the same thing goes with the spleen. I do the super effort of avoiding the splenic vein in a 5-centimeter tumor where there are 2 lymph nodes around it. And in that case, I'm a little bit more pragmatic, and I do distal pancreatectomy with the spleen. Totally agree. Daniel, sometimes reality is a little bit different from theory. I totally agree with you. All right, and here it says a very surgical concept. I believe that here we're speaking among surgeons. The resection of the primary tumor, even in the presence of metastasis, can also offer potential benefits. Number 1, for the control of the symptoms of the tumor, and number 2, for survival. Do we agree with this concept? Or distant metastasis is contraindicative of the resection of a primary tumor that is locally resectable? Oscar, I believe here, and I will address this question. The first part was confusing. Everybody speaks about enucleation as if there was a marginal resection. If we are speaking of a neoplasia that with the potential of going malignant, we have to consider the limits. And I pose this: do you consider that enucleation is enough, that there's no surgical margin with the face of a tumor that has the potential of being malignant? And in fact, it depends on the group experience, the location of the surgery. And if the lesion can be resected, but in the presence of metastatic lesion, the excision of the primary lesion will not modify the biological behavior in the face of metastatic disease. That is clear. That is perfectly clearly defined in any neoplasia, even if it's indolent. When we do control of the primary lesion, even if it's resectable, it is metastatic. When there's symptoms, if it's distal with infiltration to the celiac plexus, if you have metastatic disease, hepatic disease, and resectable and primary one, the circumstances are different in that case because the metastatic hepatic disease, like colon metastatic disease, are among the two pathologies that when you reach the R0 resection, in that case, you have a survival prognosis factor different from other different metastatic diseases. It's important to control the primary tumor, and it's important to achieve the metastatic control, speaking in the resection specifically, not going into the transplant. So I think that these are the circumstances that one has to consider when speaking about the primary resection. In the presence of metastasis, would anybody like to share their opinions about this? Without a doubt, the symptomatic primary tumor resection in most of the cases is going to control the symptom. Does anybody agree that it improves the survival of these patients? Or is that utopia?
That's a very good question, and one that I debate often with colleagues who do a lot of neuroendocrine tumor surgery. I don't know that we have strong evidence to tell us it improves survival. We certainly have retrospective selection biased data suggesting that it might, but again, it's all biased by the retrospective nature of the studies. I think the symptom control is the most important thing, but here it's important to stress the difference between small bowel neuroendocrine and pancreas neuroendocrine. Yeah. In small bowel, we talk a lot about resecting the primary to prevent future horrible disease that make patients miserable. It's also a resection is associated with very low mortality and morbidity in small bowel resection. Pancreas is completely different. Number one, they have a shorter prognosis, so we're not talking about the same survival to start with. And then number two, the morbidity and mortality is much higher. And lots of the symptoms from primary pancreatic neuroendocrine tumors can be managed with other modalities such as radiotherapy, for example. So in general, I think there's not a huge role to resect the primary in the setting of metastases. With the one sort of opening in this field would be for distal tumors, so tumors in the tail of the pancreas requiring a distal pancreatectomy. There might be some data that suggest if we resect the primary, we might improve the ability to treat the metastases by reducing the tumor burden. So there is a very small case series out of Italy where they removed the primary tumor before initiating PRRT on metastatic disease. And those patients that had their primary removed before the PRRT treatment, and both groups were amenable to resection, and just one group decided to have it and the other said no. Those patients that had the primary resected fared better and had a better response to PRRT. So that's emerging data, and I know they have a prospective trial going on for that right now. So that might provide more rationale for it in the future, but right now I'd say it's a fairly limited indication.
Thank you, Judy. Very, very, very well point. Bien. ¿Qué pasa con los pacientes?
Now, what happens with the patients that we do surgery on, the impact on surgery on the survival of these tumors? The very optimistic say that the patients that receive the benefit of surgery are going to have a survival of 114 months compared to those that were not candidates to receiving the benefit of the surgery. They have a survival of 35 months. This statement is done matter if the disease is localized, regional, or metastatic. Now the approach. Now minimal invasion, MIS, like we said in the morning, I think it's minimum access because the invasion in a pancreatic surgery is always greater. So the excision, it will always be a major invasive. It changes important metabolic changes. Any predilection or any preference, or it's really the same? Would anybody like to share the benefits in survival, costs? I think that the approach depends more than the equipment. It depends on the surgeon and the experience. You are not trained in open surgery, and then we will change to laparoscopic. Has a long learning curve. You pay the price and the patients pay the price. What's the best surgery? The one you do better, because surely that will have mortality and morbidity associated to your experience. The important factor here is the surgeon. Now, we refer to literature in robotic surgery for pancreas. I think that the trend, very likely, and here I would like to hear the comments from our colleagues, is towards the fact that less morbidity, very likely, because of the access and the evaluation and technology with robot for pancreas. But for this, we still do not have consistent evidence. Laparoscopic, there's a good debate, but it requires a longer curve and even more than open. And you need the volumes, both circumstances that determine the best approach. First of all, will be the volume of the center. That is something important per surgeon and center, and evidently the experience. You should measure your mortality, morbidity, that you are in the ranges at an international levels.
Peter?
Yeah, I'm not sure if the approach, whether it's open laparoscopic robotic, matters as much as the oncologic operation that we do. I think we just have to remember that by definition, the patients with neuroendocrine tumors have soft pancreases. So therefore, usually they do have high rate of leak even after pancreatic duodenectomy. So no, I don't think the approach matters so much as well as how well you do that operation, as my previous colleague said. But I also do agree. I mean, the pancreatic surgery, I think we all agree that it should be done at a large volume center that does analyze their data, as well as you have the entire team there so that your outcomes are good.
Okay, thank you. Daniel, ¿alguna opinión al respecto?
Daniel, your opinion?
Sí,
I totally agree with Rafael and with Peter in two additional aspects that I would like to add. First, in the same line, following the same line, these surgeries must be done in high volume centers. And in these high volume centers, that's where the innovation and technology is used. And in these parameters, there is enough information showing that the results post-surgery, not necessarily oncological, but post-surgery, can be better for distal pancreatectomy through robot or minimum invasion, basically. So in this context, I believe that that would be the ideal, because the bleeding and the recovery and the pain after the surgery is better. On the contrary, I believe that the reality of doing minimum invasive surgery, MIS, for the Whipple of pancreatoduodenectomy, it requires not only the high volume center and a program, but volumes, specific volumes and learning curves that are not realistic. There are certain very specific centers, and they have certain skills and very specific skills. So I would say that MIS duodenectomy, laparoscopic or robotic, has a less role than the distal pancreatectomy. It seems that our time is disappearing. I do not know a surgeon that does not has to render results. Let's speak about the results that we offer with surgical treatment of these patients. They're very optimistic studies. The progression-free survival is 90% at 5 years in those resections that were done with the existence of synchronic metastasis. That means that on time, the surgery done on time makes a difference. And survival, medium survival, and we're going back to consider the grade of the grade 1, it goes up to 12 years, but that when we're going to treat a grade 3, a G3, survival drastically reduces to less than 1 year. The recurrence of these tumors independently of the resection and everything else, considering that there was an R0 resection, 27% of them have a recurrence at 3 years and 40 of them will have recurrence at 5 years, which then makes us pose the question, what are the independent prognostic factors for this recurrence? Because from that will depend the type of monitoring after the surgery that we're going to do or apply for our patients. The literature expresses a symptomatic tumor greater than 2 centimeters, KI 67/20, and evidently positive nodes as independent factors for risk for the recurrence of these tumors. The follow-up, evidently, like in any other follow-up, is going to have the objective of offering an effective treatment in the case of recurrence. If not, why monitor? Let's not waste the resources in that. What guidelines are we using? Because in the case of pancreatic cystic neoplasias, we have 6 or 7 different guidelines. I'm just sharing a couple of the ones I found. Do you have a preferred one? Or I did not include the one that you're using, and I did not include, Julie?
So I have a preference only because my center participated in that guideline. So we helped build a COMNETS Neuroendocrine Tumor Society guideline for monitoring, and then a lot of that was transferred into the North American Society guideline. And essentially, they're very practical guidelines, and they're expert consensus based. It's all expert opinion. There is no evidence there. The only evidence we had is that recurrence happens often, as you showed very well, and it happens over the course of 10 years. And even after 10 years, it doesn't go down. It sort of plateaus, but it's still quite high. And so what those guidelines stress is we have to adapt the monitoring strategy to that. And so in general, the baseline is like imaging with triphasic. So the arterial phase we mentioned early in this discussion is very important. Every year to every other year to start, and then at least for 10 years. And after 10 years, we can discuss with the patient whether we continue or not, but it's for a minimum of 10 years. And there are certain circumstances where you might consider more frequent follow-up, such as the high-risk features that you just listed on the prior slide. But it's just, again, like neuroendocrine tumors are unique, and we have to approach the monitoring and the surveillance very differently than we would other types of cancer. So longer intervals, but also longer timeline for the monitoring.
Muy bien. Gracias, Julie.
Thank you, Julie. Because of time constraints, we're going to move ahead. And I would like to say that when proposing an objective method and a quantitative method to determine the follow-up, and this was published by SIDE 2019, it considers the size of the tumor, it considers the percentage of KI 67, and it also considers if there are positive or negative lymph node, giving a specific score to each one of the items. The minimum is 0, maximum 10, and based on this, they stratify the groups in low risk, intermediate, and high. And here you can see the scores for each one of the strata. And the important thing is to evaluate the risk of recurrence at 2 years. When he classifies them in 2 years, the risk of recurrence at 2 years is 2%. When it's intermediate, it's 14, and when it's high, the recurrence risk is 33%. Based on this, he establishes the intervals for follow-up in months. For the low risk, it's 12, for the intermediate, 6, and for the high, it's 3. And with this, we would close our conversation, and I would like to hear comments, the closing remarks for each one of our brilliant panel members. They have all shown that they are experts in this topic, and I thank you very much for your comments, for your participation and the comments with this presentation that was quite had a big scope. Ladies first, here in Mexico, that's what we say. Julie, if you will, can you please start with a brief comment for closing remarks and conclusions? We have 2 minutes, 3 minutes.
Okay, so very briefly, I think this was a spectacular discussion, and I certainly learned a lot from my colleagues as well. The one thing I would say at the end is, when we think about neuroendocrine tumors, think about them as different tumors. Don't think about them as we think about other types of cancers in all aspects. And there's no one size fits all within the neuroendocrine tumor. There's lots of tailoring that goes into that. And with that, muchas gracias para la invitación. And I will leave other words to my colleagues.
Thank you, Julie. Peter, please.
No, thank you again. It was a great opportunity for me to. That was an amazing presentation and a really good discussion, and I too learned a lot. And it was a privilege to me to be part of it. Thank you.
Thank you, Peter. Daniel.
Gracias, Oscar. También.
Thank you, Oscar.
Muy bien llevada la presentación.
The presentation was well led, and you touched on all of the topics that are important and controversial. And likewise, that made it so that we all learned. I also learned a lot from hearing the opinion of others. It's interesting to see how practices can vary. And once again, thank you very much. It's truly a pleasure to be here with you once again. And I hope that soon we can meet in person. Thank you, Daniel. We expect the same thing. Likewise, Rafa. Thank you very much, Oscar. Thank you to all my colleagues, excellent speakers. And I would close by saying 2 things. The first thing is that in order to treat a neuroendocrine tumor, we have to consider them. Thanks for this module, because a neoplasia that was an orphan, we see that it's not so. And this is important, and I hope that we do this again. National experience and the experience of the countries is important. It gives us a lot of room for conversation. And we also have GenMeds. We have another association for the study of these neuroendocrine tumors. Rafa, thank you very much. I'm very pleased to have coordinated this meeting of experts. I hope that it's of use for all of our attendees that we've had for these 90 minutes. I would like to share the good wishes of Daniel that in short we will meet directly and we can embrace and discuss this live. That makes a difference, even though definitely speaking, the technology has had its place. I embrace you, warm greetings, and we thank the audience for hearing us, and we give room to the last session of the day and the conference as well. And thank you very much. Good evening.